السلام عليكم. هاي المحاضرة is about mesenteric ischemia, and here just a case presentation, emergency room presentation with a 53-year-old male patient who came with abdominal pain, anorexia, nausea, vomiting for the past 5 days. He is a smoker, social alcohol drinker, and there is nothing in his past medical history. The patient clinical examination revealed low-grade fever, tachycardia, abdominal distension, and diffuse abdominal tenderness with absent bowel sounds. Investigations: full blood count, UNEs including kidney function test, liver function test, CRP, ABGs, abdominal and chest X-ray. I'll pause here for a second to let you think about what would be your next step of management. So what would you do is this patient will need IV fluid resuscitation. You need to catheterize the bladder and measure the input-output. Would you give antibiotic? Does the patient need IV antibiotic? And what would be your next step? So this was his abdominal CT scan, and as you can see that there is a clot inside his mesenteric artery, superior mesenteric artery, and you can see here thickening of the bowel wall, the sign, we call it target sign. And this is again the CT scan finding correlated with the gross pathology. You can see how is the bowel wall is thickened on gross pathology. And in this slide it shows the intramural gas, and on the lung window of the abdominal CT scan you can see the gas is more obvious inside the bowel wall, and this is quite advanced sign of bowel ischemia and necrosis. And on this image you can see that there is paper thinning on this CT scan due to the ischemic changes of the bowel wall. So what would you do next? Again, here I'll pause for a second to let you think. Yes, you need to take the patient to theater. So this is a laparotomy, midline generous laparotomy incision, and as you can see here is lobes of small intestine, and obviously these bowel lobes are ischemic and non-viable. You can see here is the demarcation line. That's the dead bowel, and this is a viable bowel. Again, here is the demarcation line. This is dead, this is viable. And this is the amount of the bowel which was resected. It's quite extensive. As you are aware, the superior mesenteric artery supply the majority of the small bowel. And you can see here is a clot from the main branch of the SMA, which was causing the occlusion and this catastrophic consequence of its presence. So acute mesenteric ischemia is one category, and you have another category, chronic mesenteric ischemia. ischemia. The pathophysiology of acute mesenteric ischemia, it can happen either due to arterial embolization, arterial thrombosis, vasospasm or non-occlusive mesenteric ischemia, or venous thrombosis. The arterial occlusion is the most common, which accounts for about 2/3 of the cases. When there is bowel ischemia, as you are aware, 75% of the blood supply to the bowel goes to the mucosa, so the mucosa will initially suffer. The integrity of the mucosa is lost, and that will result in bacterial translocation and toxin release into the circulation. Also, there will be edema and thickening of the wall, systematic effect of the presence of bacteria inside the circulation, or septicemia, and reperfusion injury. This slide will show you the percentage of presenting symptom. The most common presentation of acute mesenteric ischemia is abdominal pain, which was found in 96% of the patient. Nausea, vomiting, peritonitis, diarrhea, all could happen. And in this mesenteric angiogram, you can see here is the presence of proximal SMA occlusion due to thrombosis, and distally here you can see a clot due to embolization. So both could coexist in the same patient. The usual site for SMA thrombus is usually in proximal, close to the origin of the artery from the aorta, and the embolus usually is more distal, where a clot will get impacted in the small narrow branches along the distal area of the artery. Acute mesenteric thrombosis, when there is progression of the superior mesenteric artery thrombostenosis to complete occlusion, typically in heavy smoker females, and the presentation are similar to the embolization. In 65% of the cases, there is a history suggestive of chronic mesenteric ischemia due to the narrowing or atherosclerotic changes of the SMA, and these are usually present as weight loss due to postprandial pain, constipation, and could be on occasions confused with pancreatic cancer or stomach cancer. Fortunately, the small bowel does not get mesenteric ischemia due to the configuration and the way it receives its blood supply. There is the arch of Riemann or arch of Drummond or artery of Drummond, and these are collateral, connecting the SMA with the celiac and the IMA, and that will help to prevent ischemia if one of these branches gets occluded. And this is artery of Drummond, nicely seen on this photo. When you do laboratory test in patient with mesenteric ischemia, the results will show you derangement of the lactate, CRP, white cell count, creatinine, and BUN. However, the difference, or there is no way to differentiate between if this is embolization or arterial thrombosis or venous occlusion. Mesenteric vein thrombosis could be categorized into two: either inherited hypercoagulable state, such as protein C or S deficiency, antithrombin 3 deficiency, hyperfibrogenemia, or polycythemia vera, acquired such as in acute inflammatory pathological condition, smoking, oral contraceptive, HIV, malignancy, previous abdominal surgery, etc. Now, in this study, which was carried out in Qatar, and the common age to get mesenteric venous thrombosis is the middle age, 40 to 50, and in this the commonest acquired or inherited condition causing thrombosis was antithrombin 3 deficiency. And this slide just show you that there are several studies looked at acute mesenteric venous thrombosis, and the numbers they are quite low as this condition is infrequent. How to treat it? Methods of treating superior mesenteric artery embolization include anticoagulation, resuscitation and correct acidosis, CT scan with contrast, and emergency laparotomy. And in that case, you have to remove all the dead bowel and do embolectomy to improve the vascularity and the circulation. Second look laparotomy is a must in those cases. So how to do revascularization? You have to try your best to avoid putting a prosthetic graft in contaminated peritoneum when there is dead bowel and perforation and release of the bowel content. Direct reimplantation of the SMA is another method. Endovascular treatment also is an acceptable option, and in this study it showed clearly that the symptoms disappearance is comparable in both approaches. The main advantage of the endovascular treatment is that the mortality is less. You can see that the mortality with open repair is higher compared to the endovascular treatment. One novel approach is to do retrograde mesenteric stenting during laparotomy to improve the vascularization and the circulation of the bowel. And in this article they were claiming that there is a benefit for doing laparoscopy in acute mesenteric ischemia. Future development: thrombolytic therapy for acute superior mesenteric artery thrombosis. And this slide will just summarize the survival for different causes of mesenteric ischemia. The prognosis is usually better for mesenteric venous thrombosis compared to mesenteric artery embolization, and the mesenteric artery embolization has a better prognosis compared to mesenteric artery thrombosis or non-occlusive mesenteric ischemia. Surgical mortality is quite high, but the mortality for mesenteric artery embolization or venous thrombosis is about 50 and 32%. For the mesenteric arterial thrombosis or non-occlusive, as you can see, the mortality is higher, I mean surgical mortality, and overall survival luckily has improved over the last few decades due to improved understanding and management techniques. This slide will just summarize how to manage people presenting with acute mesenteric ischemia. If there is peritonism, urgent scan and take them to theater, preferably with vascular expertise, and consider always second look laparotomy or laparoscopy. If there is no peritonitis, also you can do CT scan. Think about mesenteric angioplasty or thrombolysis. If the patient develops peritonitis, take them to theater. If they remain without evidence of peritonitis, carry on with your conservative management.